things that I have prayed and just would give anything to see in 5 years, I've seen it now in 4 weeks. By day 2 of life, Luke started to go into a coma. The first 6 months of Luke's life were very traumatic, to say the least. He was in the hospital every week. We would get out for a couple days and be back. His pneumonia was just never really managed. For 6 months, he stayed at a brain damaging level. Every time I would see a doctor, they just pick one diagnosis to fixate on. So Luke has been given a diagnosis of CPS1, he's had a liver transplant, metabolic stroke, cerebral palsy from the stroke, and we also got an autism diagnosis. There were many nights that I would stay up crying, thinking, what can I do for him? Because I feel like everything I'm doing here is not working. Dr. Crawford takes us back, and he was looking over Luke, talking to him. He didn't treat Luke like any of his diagnosis, not one of them. He was looking at Luke to treat Luke what works best for him. This is a place of miracles. So before, I could never get Luke to like dress himself. And the other morning I had his clothes laid out for him, and I was in the bathroom getting ready, and I walked back into the bedroom and he had already gotten himself dressed. He was completely nonverbal from the stroke, so never said a word, but he has started to talk. I was like, you get to go to clinic today and see all your friends. And I was like, are you ready to go now? And he said, yeah. And now he's trying, like every night he's trying to sound out words. He actually sits at night and in bed and wants me to read to him. He's never done that before. He was not ever using utensils. And I've made videos of him since being here of eating his first cup of ice cream, like literally from Chick-fil-A, because he can do it now. I just have so much hope for Luke's future, and just seeing the things that he's done in 4 weeks. I can't imagine what it's going to look like for him when we get home and we're doing home care. Who knows, maybe a year from now I will be sending y'all T-ball pictures and whatever he wants to do.
You're doing awesome, dude.
This place is restoring health, restoring hope to families, and truly changing lives, not only of the patients, but of the families as well.
Hi everyone, thanks for being here. Thank you so much for Team Luke for organizing another fantastic conference. My name is Dr. Amanda Ryskowski, here to talk about Shockwave, extracorporeal shockwave therapy, or Shockwave for short, because that's a lot easier to say, and how that can be integrated into treatments for spasticity. So I'm practicing out in Surprise, Arizona. Most of my patients these days are cerebral palsy, HIE, anoxic brain injury. But I also, with my background in regenerative medicine, I also enjoy fixing the occasional rotator cuff tear or labrum injury, things like that. So I do see patients of all ages, but primarily kids these days. Can you hear me okay? Oh, okay. Do we need to turn my... Thank you. Is that better? No.
I don't think it's on. It might just... It's just...
Oh, okay. Perfect. Okay, I'll try to speak a little louder for you in the back. Yeah. So my main goal for this presentation is for everyone to walk out feeling more informed about decisions for local interventions in spasticity management. So in order to do that, we're going to talk a little bit about some of the limitations of the kind of conventional approach, as well as some of the emerging research on both Botox and Shockwave, and discuss the implications of that for what that might mean for your child. So as I think everyone in this room is well aware, people with any kind of neurologic injury can deal with spasticity, and often it can be quite debilitating. So this can be a really, really major hurdle for people who are suffering from it. But it doesn't have to be from a neurologic injury necessarily. Actually, anyone who's experienced severely limited mobility at some point in their life can develop some spasticity related to that. These are just a few definitions before we get started. Technically, spasticity refers to the hyperactivity of the stretch reflex, but I might use it interchangeably with some of these other terms, hypertonicity or high tone. Fibrosis refers more to the kind of thickened connective tissue that we see in spasticity, as well as muscle stiffness. And eventually these things can lead to contractures. So you might see some overlap in this terminology, but I just wanted to phrase that here. And contrary to kind of the conventional assumption, spasticity is not purely neurological. So while of course it's generally initiated that way, there are a lot of local changes to muscle architecture that end up perpetuating spasticity. And I think cerebral palsy is kind of our classic example. It's a non-progressive brain injury, but the spasticity, the contractures develop later in life. And so it suggests that there's a really important role being played by those local changes to the muscles. And my slides are just kind of doing their own thing. Namely, it's that thickening of the extracellular matrix, which we'll cover here. So this is a microscopic view, oh my goodness, of muscle tissue from neurotypical patients compared to patients with cerebral palsy. So this study compared patients who were undergoing a hamstring lengthening surgery, and so they were able to take little samples of that tissue and look at it under the microscope. This is stained for collagen in red. So the patients with cerebral palsy, as you can see, have far more collagen deposition in that extracellular matrix. These are just two different views. And as well as hyaluronidase deposition. So the image on the right is actually from a rat study, but you see kind of a similar change where these rats did not have any kind of neurologic injury. They just immobilized their legs for 4 weeks. And you see the same kind of changes where that connective tissue gets really thick. In this case, they were staining for hyaluronidase. So as it turns out, really both collagen and hyaluronidase, because they're really the two main constituents of the extracellular matrix, both of them get very thick and hypertrophied in spasticity or muscle stiffness. And this is what that looks like on ultrasound. So you might be able to see, so the last image was more of a microscopic view. Now we're seeing what we might see actually in the clinic. So on the left is more of a healthy muscle tissue without any significant fibrosis. And then it gets progressively worse as we go to the right with those white patches getting thicker and denser. Those reflect the changes in the fascia. So fascia is getting more dense and hypertrophied as we progress, eventually kind of losing the regular architecture of the muscle. And so some of the things we know happen in fibrosis of muscles, we get that thick extracellular matrix, which is actually weaker than it's supposed to be. We see more collagen and hyaluronidase deposited. This all kind of inhibits the ability of cells to migrate within our muscle tissue. And we actually know that on average, the muscles of patients with cerebral palsy have about 50% less stem cells than control muscles, largely due to these changes in the matrix. And so as a result, the muscles tend to atrophy. We can get some fat deposition in there. The fascia gets dense, disorganized, and we kind of lose the architecture of the muscle. So all of that changes the way our proprioceptive cells in the muscles transmit forces. And so the stiffer the muscles get, the more exaggerated that stretch reflex becomes. And so this becomes kind of a vicious cycle in managing spasticity, where the more fibrosis we develop, the worse the neurologic reflex also becomes. And as everyone in this room, I'm sure, is aware, Botox is the #1 local intervention for spasticity in kids with cerebral palsy. I put that quote in the corner just as a reminder. It is one of the most potent biological toxins in the natural world. And so this is just something that has to clearly be used, very intentionally. The image just shows how it works with the botulinum toxin inhibiting transmission at the neuromuscular junction. So it just causes a partial paralysis of the target tissue. And so it, it definitely reduces spasticity in that regard because we're causing a partial paralysis. But we have to kind of look at the research, I think, a little bit more critically these days. So despite widespread use, there's actually very little long-term research on Botox. Of course, Botox has fantastic marketing. They have spent many millions of dollars on clinical trials, and a lot of them are short-term, under 6 months. Most of them are focused are purely evaluating spasticity reduction, and they aren't necessarily looking at the gains of function. So some of the changes we know happen with Botox injections are fibrosis and atrophy, and especially with repeated injections. So while the benefits of relaxation last for a few months, the side effects of fibrosis can in some cases be permanent or long-standing, especially with repeated use. And so these are more changes that you see with Botox, fatty infiltration, fascial dysfunction, all things that we discussed with the, on that muscle fibrosis slide as elements that perpetuate spasticity. And we know, this has really become pretty well accepted in recent years that for non-ambulatory children, the risks definitely outweigh the benefits for Botox. This was from a large systematic review published in 2019. So there's higher risk of adverse events as well as decreased benefits that can be achieved in non-ambulatory children. And we also know that treatments get less effective with time. So this study evaluated 144 kids with cerebral palsy, and the first injection yielded more benefits than any of the other subsequent injections. Now, in about 10% of the population, part of this may be attributed to antibodies that people can develop, which actually neutralize the toxin. But for the rest of the 90%, I suspect that the decrease in effectiveness is related to the progressive worsening of fibrosis and atrophy with subsequent treatments. Perfect. So this was a 2-year placebo-controlled trial that came out actually quite a while ago in 2008, but they took 64 kids with cerebral palsy and randomized them to either receive Botox injections or placebo, just saline injections, every 3 months for 2 years. And they were focused on the lower extremity, but this is not atypical of a treatment regimen. And these researchers really focused on the functional changes rather than just measuring spasticity. And they found no persisting benefits in the group that received Botox for 2 years. And this actually just came out last month. So it was a 3-year study following kids who were receiving Botox injections. These are all ambulatory children, so the ones who are theoretically good candidates for Botox injections. And they just received whatever injections that were deemed necessary over a 3-year period. They were also focused just on the lower extremity or leg muscles. And they included a variety of different outcome measures, including spasticity as well as functional scores. And so the results, I think, were pretty striking. So when you look at all of these different functional outcomes, these are functional and mobility outcomes here. There was no statistical difference between the group that received Botox and the group that did not. Now, there was a statistically significant difference in these two areas, which is the ankle range of motion shown here in this image, just with the knee extended, how much can we stretch that ankle back, and the hamstring range of motion. However, the correlation was not in the direction that the researchers were thinking. It was actually that the Botox group had worse range of motion after receiving treatment for 3 years. And so not only did we not see improvements in gross motor function, but it actually worsened range of motion over the course of 3 years. And so this really requires us to reevaluate the way we're utilizing what is currently the #1 intervention for local spasticity. So it is clear that we're overutilizing Botox in cerebral palsy and other neurologic injury populations. And while it certainly can provide short-term relief, the side effects can be really long-standing and can be something that we have to work hard to overcome in later years. So I think it's becoming difficult to make a case for long-term Botox use at this point with some of the new research that's coming out. I think that short-term use certainly can be worthwhile in certain cases, but we have to be really intentional about it. And and we have to have an exit strategy. So if, for example, the hips are in a really vulnerable position, we don't have access to other alternative treatments, things like that, then we might need short-term use in some cases. But we definitely should not be using it as much. You're fine. As much as we are currently, and we really need better alternatives. So. Thankfully, that's what we're here to talk about. So I need a Hawaii break after talking about the Botox stuff because this can be weigh heavily on me sometimes. But I spend a lot of my time trying to find better solutions for my kids who are dealing with severe spasticity because it really is so debilitating. And so enter extracorporeal shockwave therapy. This is where we use sound waves to generate mechanical forces within tissues. The diagram on the left illustrates like a radial device. So it's kind of a really fancy air compressor. We're just using air compression to kind of like as if you dropped a rock in a pond, create this kind of ripple effect within the tissues. And these are examples of different types of shock waves and how they might be distributed throughout the body. The main two types you'll see out there are radial and focused. Technically speaking, radial shockwave, this gets confusing, is not a true shockwave. So it's technically a pressure wave compared to a true focused shockwave. But in the literature, we usually call it shockwave. So that's generally how I'm going to refer to it. They're different in the ways that they are distributed through tissues. So radial has this kind of wide distribution effect, and focused narrows into a certain point. And so focused has a really small area of focus that tends to be deeper, whereas radial is more effective superficially and has a really wide area of coverage. There are some newer kinds coming out these days too, like unfocused is getting pretty popular in sports medicine. I didn't include it on here because we frankly have very little research on unfocused shockwave. However, it seems to have benefit. We just don't know as much about it and what it can be used for. And to make it more confusing, sometimes radial shockwave we call EPAT, extracorporeal pulse activation technology. So just all the different terminology you might see out there. Shockwave really revolutionized kidney stone treatment in the 1980s, and so it looks quite different than the kind of thing we might see in a clinic these days. But it has the power to dissolve kidney stones, and I thought it was pretty interesting that in kind of some of those early years in the 1980s, some of the clinicians back then started to notice that the side where the kidney stone was treated actually had kind of a crisper bony outline on the x-ray, indicating a benefit to bone density. And so that was what spurred a lot of the interest in musculoskeletal applications of shockwave therapy. So now, about 40 years later, we have way more research on the benefits of shockwave therapy. These are just a few of the physiological effects that we know to happen. Immediate improvements in blood flow, reduction in myofascial tension, increased bone density, as well as if you used focused shockwave, you could heal a stress fracture a lot quicker, or like non-union fractures can be healed with focused shockwave. It reduces swelling in the bone, like for patients with arthritis. And it modulates the pain pathways as well. I know. There's also, some evidence. It's a fairly new area of research, but there have been a few studies in the last few years to show that it may have the potential to regenerate nerves as well. And so this is, I think, an exciting area where we'll continue to see more development. This is just a little screenshot from an international Delphi study that came out this year, actually. So they interviewed a lot of different experts in shockwave therapy from around the world, and they asked them, what does shockwave work for? So this is just a small screenshot from that study. There's a lot in it, but these were some of the top conditions that everyone agrees shockwave works for, ranging from plantar fasciitis, Achilles tendon issues. It's very effective for those things. And those are, frankly, really painful conditions to receive injections for. So I was really excited to have an alternative to doing like PRP, for example, for that stuff. And as well as, a variety of different tendinopathies. We have, so many listed here. Most tendinopathies can be treated with shockwave. There's just so many benefits to the muscle, tendon, bone, ligaments, all of the above. Even low-grade tendon tears can be treated with shockwave as well. And specifically when it comes to fibrosis, these are some of the changes that we know to be, to be stimulated by shockwave. So it enhances recruitment, migration, and differentiation of mesenchymal stem cells, which we know to be deficient in cerebral palsy patients. It stimulates turnover of the extracellular matrix and helps break down collagen faster. It also stimulates new blood vessel formation and a lot of different growth factors that we need for healing and remodeling of tissue. So what does that mean in practice? We have this study evaluated kids with cerebral palsy who were given 5 treatments of focused shockwave, and the reason I included this paper in particular is because they took the time to include some elastography. So elastography is when we use ultrasound to actually quantify the stiffness of the muscle, which is really helpful in these studies, and not a lot of studies include it. So, so they did a really short treatment of just 500 pulses, but they did 5 sessions of that, and they evaluated just the soleus muscle, so really focused study. And that then they followed patients for about 6 months. So they found that the focused shockwave reduced muscle stiffness, with the maximal benefit occurring about 9 to 12 weeks after treatment. And then after that, the effects kind of progressively declined. Of course, these are young children, so they're actively growing. It's, I think, different in adult patients with stroke. So muscle stiffness strongly correlated with spasticity, as we could expect. And so based on the duration of almost 6 months, the authors suggested at least 2 treatments per year. Now in this study, the researchers had more of a focus on the functional outcomes, which is why I wanted to include it too. So they looked at ambulatory kids with cerebral palsy, kids and grown-ups actually in this case, and they gave them 3 sessions of radial shockwave, 1 week apart, and 2,000 pulses, which is a little bit more, I think, typical in the research and in my practice. and they did kind of a stronger intensity. So they were focused on the lower extremity muscles. And some of the tests they included were things like the timed up and go test, where you have to stand up, walk 3 meters, go around the cone, come back, sit down. And they found that the radial shockwave increased passive range of motion in all muscle groups, and all of that was really statistically significant. They found that spasticity or stretch reflex was also decreased, although there were a few in this study that weren't statistically significant, but it's a small study. The functional improvements were pretty striking. So the image on the left is of the timed up and go test. So in this case, the lower score, the better, because the kids are getting faster. And they saw really significant improvements, with the benefits actually extending throughout the study period of 24 weeks. So unlike the muscle stiffness elastography study, where we saw that kind of rebound in spasticity, the functional improvements here just kept on going. And with the 10-meter walk test on the right, in this case, the higher score is better because the kids are walking faster. And similar changes where the kids are getting a lot faster, and those benefits were sustained throughout the 6-month period. So as it turns out, we actually have a lot of research on Shockwave. In 2024, this was published. They counted 427 publications on Shockwave for spasticity, and of which 305 were for stroke. Cerebral palsy would probably come in second there. And this review looked at 16 different scientific studies, all of which demonstrated improvement. And so I just think it's really interesting that despite how really robust of literature we have on this, nobody seems to know about it or be offering it. So we're hoping to change that. This is a nice, I just appreciated this diagram from that review with just showing the spasticity and how it might be applied to yield benefits there. And then this was also from the same review. I just appreciated this slide because they listed some of the different physiologic changes and benefits, mechanisms from shockwave therapy. They suggested a break in functional link between actin and myosin helping to reduce stiffness. And and when we reduce that local stiffness, it actually has a benefit neurologically in reducing spasticity. This study I wanted to include because they evaluated Shockwave applied after Botox injections. And so it was a small study. They just looked at 10 kids who either received Botox on its own or Botox plus Shockwave afterwards. And so it was only 5 kids in each group, so quite small, with ambulatory status kind of ranging like level 1 through 4 in this study. But they also included elastography, which is what I really appreciated here. And you'll find the HECMET scale is more that visual grading in fibrosis. It's a little bit less in depth than something like elastography, which really gives a quantification of it. And so they found, visually the fibrosis looked similar between the groups, but when you measure the elastography, it was way better in the group that received Shockwave. And spasticity also improved significantly more in the group that received Shockwave, indicating that we had, not only did we have a kind of a combined effect where it led to increased benefits of relaxation, but it also suggests it might be reducing the fibrosis right away that Botox can cause. So I think it's a really interesting area of research there. But I think what we all really want to know is how did the two compare head to head? What is my computer doing? So this was a study where they directly compared Botox injections to Shockwave therapy in a group of kids with cerebral palsy. So it was a crossover trial, so that means that everyone who received Botox initially was followed for 6 months, and then they had the opportunity to receive Shockwave at the end of the study. And same vice versa. The kids who received Shockwave first were followed for 6 months, and then they got Botox injections. And this was all focused on the calf muscles. Oh my gosh. So they found that both treatments reduced spasticity. Oops, did I skip one? Okay. Oh my goodness, sorry. There was a general trend towards better results in the Shockwave group compared to the Botox, but it wasn't quite enough to be statistically significant. So they were able to say that both improved pretty similarly. However, there were some areas in which they were pretty different. So with regard to duration of benefits, by the time they checked in at that 6-month mark before the kids crossed over, the group that received Shockwave first was in a better place. So it actually had longer benefits than the Botox group. Excuse my jumpy slides here. So it demonstrates that Shockwave benefits last longer, as well as had way less pain. So this is just a pain scale with Botox injections in white, kind of averaging like 6 or 7 on a 10 scale, and then Shockwave group wrote like a 3 or 4. And this was actually the first study to compare Shockwave directly to Botox. It was published in 2018, and this was for patients with stroke. And so they were just looking at muscles involved in elbow and wrist flexion, and patients either received 3 Shockwave sessions or 1 session of Botox injections. And all those kind of parameters are listed here. And they found really comparable benefits with spasticity. So these are all different measures of spasticity here, in which they yielded really similar benefits. But the place in which they were quite different was with function and range of motion, with, as you might guess, the Shockwave group outperforming the Botox group really significantly in function and range of motion. This is just kind of a composite of all of those different responses with spasticity, function, range of motion, trying to show both are helping. Shockwave helped more. So the authors are able to conclude that at the very least it's a non-inferior treatment alternative, but according to the study, it really outperformed Botox. And so I know we've talked about a lot of different studies with really variable protocols, radial, focused, all of those things. And both of them seem to be beneficial. In cerebral palsy in particular, we have way more research for radial shockwave. Radial shockwave devices are also cheaper and generally more accessible than focused. But according to some of these reviews, both are beneficial. And the interesting thing is, despite how variable the treatment protocols are in all of these studies, they all work. So we might have a lot to do. There's a long way to go in terms of understanding what protocols are most efficient, but all of them are really beneficial, which is the good news. This study actually compared radial versus focused. It's one of the only papers I was able to find that did that. And so they were looking at stroke patients with calf spasticity, and they either received focused or radial and really comparable parameters otherwise. And all of them benefited, all of them showed improvements. But in this case, the radial group had more improvements when it came to passive range of motion and plantar contact area, or like the amount of the foot that came in contact with the ground when they're walking. We have research showing kind of complementary benefits when Shockwave is paired with other interventions, whether it be Botox, orthobiologics, physical therapy. Mirror therapy is a type of physical therapy. But these are just things that we have publications on Shockwave improving the outcomes with. And it's growing quickly. It's, for the most part, extremely safe intervention. In all of the studies basically discussed here, only side effects observed were bruising, soreness. If you go higher in intensity, it's really dependent on the settings that you use. We do have to certainly be cautious with some of the conditions listed here. With local cancer infection, because we could cause a spread of something, or people on blood thinners. We just have to be a little gentler, perhaps. The focused shockwave, you have to be more careful over growth plates or lung tissue. There's a theoretical risk of lung damage with focused shockwave, like on the pecs or something, but it's never been documented. So there's never been a case of an injury, but hypothetically, it's just something we want to be aware of. So especially with radial shockwave, there's almost, very, very few documented adverse effects in the literature. And so these are some of the key takeaways. We know that both focused and radial shockwave can be safe and helpful for treating spasticity. And while we might have a little more research on radial, I think it really would depend on the location of the muscle, the size of the patient, depth of the muscle, things like that. We know focused goes deeper, and radial is more effective in the superficial areas. Someday I'd love to see more research on the combination of the two. It also, we know that it's comparable to Botox when it comes to treatment of spasticity, and that it offers actually more benefits when it comes to range of motion, as we discussed here. And what I really believe in treating the underlying cause as a naturopathic physician. So because we're treating the underlying factors that are contributing to muscle stiffness, it works. We get better results, and it allows that muscle tissue to remodel in a way that Botox actually hinders. It reminds me a little bit in regenerative medicine of the analogy between corticosteroid injections, for example, for arthritis, and something more regenerative like a PRP. So we know steroids, we have so much literature on how steroids actually accelerate arthritis at this point, but so we're getting short-term relief at the cost of long-term aggravation. And that's not really a philosophy that I like to employ with my patients. I want to ensure the best long-term outcomes. So I think it's a really exciting area of research right now. This is me with a patient. It's my protocol's listed here. It's really, really broad. So my range of pulses, frequency, intensity is going to vary based on the patient size, muscle depth, patient tolerance, things like that. So I want it to be a comfortable experience. Typically, with verbal patients, we can kind of talk to them through it and ask, like, what's your level of sensation? Are you at like a 4 or 5? And then we might try to keep it there. With nonverbal patients, I usually err more on the conservative side. I want to make sure that it's a comfortable experience. And at low intensities, it kind of just feels like a massage. It feels really good. In my world, usually I'm pairing it with other interventions. So I really like doing it right before an intramuscular injection of something like collagenase or hyaluronidase, which helps further remodel connective tissue. And so this was kind of a game changer for my practice when I just realized how I can get much better results if I shockwave the tissues first. Also before things like orthobiologic PRP or cell-based therapies, shockwave right before really primes the tissues and stimulates blood flow, stimulates growth factors, helps us get a lot more out of the treatment. So admittedly, I'm actually relatively new to shockwave therapy. So we just got our device at Total Wellness at the beginning of this year. So it's been less than a year that we've been utilizing this, but it works so well and it improves my patient outcomes so much that I felt the need to share it this year. This is a diagram of the sensory dermatome, and this maybe is just a me thing, but I like addressing the stretch reflex at whatever levels I can. So for let's say I'm treating lower extremity spasticity, I really enjoy pairing those treatments, whether it's collagenase and shockwave in the calves, for example, with some kind of treatment at the paraspinal level so that we're addressing the stretch reflex throughout, at as many angles as possible. So the dorsal sensory nerve roots pass through the erector spinae muscles, which are some of the important muscles holding up our spine. And often we see a lot of fibrosis in those muscles in my patients with spasticity. And so I like to treat kind of at both levels, and I seem to get a little better results that way. So this is just a description of my my philosophy. You know, we want to treat spasticity from as many angles as possible, addressing the neurological component, paraspinal, and local to the directly affected muscle. And so by treating at multiple levels with multiple modalities, we can really optimize our patient outcomes. And this is just an example of how Shockwave might fit into a treatment regimen. So a lot of the ones here are things that I'm either doing in my practice or referring people for. So local muscle injections paired with Shockwave therapy, in my world, paired usually with orthobiologics as well. And then let's not forget the other factors aggravating spasticity, right? So, you know, things like constipation, sleep dysfunction, anxiety, all of these things can make spasticity worse. And if we include that, you know, that kind of holistic viewpoint, we can really, you know, minimize the aggravating factors for patients. And so I just wanted to include a list of different practitioners who might offer Shockwave locally. So a lot of I'd say number one are physical therapists. Most people are going to have a physical therapist locally who offers this. They might be using it for tennis elbow and plantar fasciitis and not realize how beneficial it could be for their neurologic injury patients. Now, you know, chiropractors as well as physicians. You don't have to be a physician to administer Shockwave. So ask around. Future directions that I'm kind of looking forward to, I hope to eventually offer elastography so we can actually quantify the changes in muscle fibrosis, because it is difficult visually to discern those changes, at least in the beginning. Usually the functional improvements in my world will come long before the visual improvements in the muscle's architecture. And then I'm really hoping to eventually publish some of my work on combining Shockwave with collagenase injections, because I've found that to just be such an effective combination. So this is just something in the works in the future, as it'll probably be more retroactive publications, but really looking forward to that. And then I just wanted to also briefly mention there are some more novel applications of Shockwave for neurologic regeneration that are emerging. So this is not available in the US yet, but there's a new form of Shockwave that can actually be applied transcranially. And the results in patients with Alzheimer's disease were incredible, actually. So they had to actually get rid of they had to offer treatment to the control group because it was deemed unethical to have some patients not receiving the treatment after how well it performed. So I think this is really exciting. You know, we're on the list to eventually get this once it's available in the US. But it's quite different from the Shockwave that you see in sports medicine. So just a reminder, you can't just apply a regular focused or unfocused Shockwave to the brain. It's I think quite unsafe. And so this is a much lower energy application that's designed for that use. And so I think that's a pretty exciting area of future treatment research. And I think that's everything I have. So I'll try to, I can leave the contact info for our clinic up while I answer any questions that you guys might have. We don't have a website, no socials, but feel free to just reach out to our patient care coordinator if you have any questions or anything. I did want to just acknowledge too, I kept hearing I had several parents come up to me really concerned that I wasn't taking new patients, so they thought I was leaving. I'm just pregnant, so I'm going to be on maternity leave for a few months, so I'm not going anywhere. Yeah. So, thank you. Yeah, go ahead.
I'm just curious if there's anything out there that we could use at home that would have similar results on like a daily basis.
Yeah, I mean, for daily basis might be a little bit overkill, I think, but certainly that's something that hasn't really been studied. The most I've seen was like 5 days in a row in the literature, and it worked fantastic. So we really just have a lot to learn too when it comes to when it comes to the frequency of treatments, what's best for people. At home, for home use, we don't really have anything like this yet. I've had a couple patients whose parents are either chiropractors or other practitioners who've been able to get a device for like their own home use or clinic use, and that's been fantastic for those patients. But yeah, usually the best option is just to look around, because there's almost guaranteed to be, unless you're in a really rural area, there's probably someone near you who offers it, and thankfully it's quite a safe therapy. So you might be given the opportunity to kind of educate that practitioner on how it could be used for spasticity. Yeah.
How does it, the e-stim?
Oh, yeah. Yeah.
Is that something that's similar to Shockwave?
It's a little different. Actually, I had a study that I think I didn't include here because I was, for the sake of time, but there was a study called the S-Bote study, I think from Italy, where they compared Botox plus Shockwave to Botox plus e-stim. And e-stim improved the results from Botox as well, but not as much as Shockwave. So, but it is in some cases more widely available too. So yeah, no, I think it's great. Yeah.
There's somebody out there that has something like a wand that like vibrates. It's one of the vendors. I don't remember what it's called, but is that Interax? Is that Shockwave?
No. So let's see if I have a. What I should have had was an image of the actual device. So let me see. It's pretty large. I can even just pull it up probably. Or you know what, actually, yeah, exactly. She's got pictures. So yeah, feel free to, I have some handouts too on what the device might look like. We have some that are, there are some alternate brands emerging, but the ones, like most of the ones that are used in the literature are by like Storz Medical. So.
You said storage medical?
Storz, S-T-O-R-Z. Yeah.
So, my daughter has been on and off Botox for years
Yeah.
now. How do you recommend transitioning from Botox to something like this? Is it just something we can just switch to and just stop using Botox?
Right. I mean, especially if we're talking about long-term use, often it's best to stop sooner rather than later. If you can find a practitioner who offers it, ideally close to home. Or I mean, you're always welcome to come out to Arizona too, but sometimes it's more sustainable to find somebody near you, and so it's something that could be switched over to right away, and you can start to treat. So I've seen a lot of patients where it's so obvious which muscles have been treated with Botox visually because they have this characteristic fibrotic change, and Shockwave just starts to reverse that right away. So kind of the sooner the better. Yeah.
And then how, I guess, is this deemed a long-term thing as well, like Shockwave therapy?
Right. I mean, we certainly still would love more long-term research on it, but given the difference in safety profiles, right, and with Shockwave being as safe as it is, the longest I was able to find in the literature was up to 6 months of benefit, but there's no reason, especially if we've had a lot of Botox in the past, we might want to do it more often to really restore that, from kind of a regenerative perspective, we're not just trying to minimize the symptoms, but we really want to heal the muscle, and so the Shockwave can start to do that pretty quickly, and then often as we start therapy, we see how the patient's responding, then we're able to kind of make those determinations as we go about how often we need it. Yeah.
Hi, I'm Benny.
Hi.
I spoke to you. My daughter's coming to see you in June.
Oh my gosh, that's you. Oh, lovely. Yeah.
She's been getting Botox since her brain injury. Her arms were up here, and now they're like placed down here.
Yeah.
So after we're done seeing you, so we shouldn't go back to no Botox. We just continue.
Right. I mean, I think in most cases, especially if we've already had multiple injections of Botox, we're not going to want to go back to it.
Okay.
Yeah.
Cool.
Yeah. Absolutely.
Okay.
Yeah. Yeah.
Okay, so on one of your slides, you were stating that. Let me see, I remember. So basically, my son has a bleeding disorder.
Mm.
We just started getting Botox. We've had one injection. We have another one coming up soon.
Yeah.
He's a
Yeah.
hip dysplasia. He's
Okay.
about 40% effaced, and it was like that would be the quickest
Yeah.
thing for us to try to
Right. Right.
prolong getting the surgery. So he's about 6.
Absolutely. Yeah. Yeah.
Since we've only had one injection so far, would Shockwave be beneficial for him since he has that 40% efface, or we're doing it for a short-term fix right now, should we stick with the Botox?
Right, right. I mean, in some cases, so that's kind of the perfect example of when Botox is indicated, because hip surgery is just so major. And so, if it can prevent that, that's huge. Ideally, if we could get both, that might be perfect. Or, of course, without having assessed him myself too, I know it's a little, take it with a grain of salt, but in some cases, both. Or, if you had access to Shockwave, then you might be able to replace it, but we'd have to be really on top of it.
And
Yeah.
what were the cautions as to why it was a caution for bleeding disorders?
Really, it's just a bruising risk. You're more likely to get a hematoma. I mean, it's relatively minor, to be honest.
The risk with anything really for him.
Exactly. We're just risking a bigger bruise. Yeah, yeah. Absolutely. Yeah.
What kind of practitioner could possibly offer the collagenase injections or hyaluronidase injections?
It's a little bit tricky these days because there's not a lot of people offering it for this population. We have a group of naturopathic doctors here out in Arizona who offer it. Occasionally, we can convince the open-minded physiatrist or local pain management physician to administer those. But there's not, unfortunately, a lot of options for that. Yeah, I really find it just a wonderful tool because it remodels that tissue so fast. I actually had a patient. I've done a short series of comparisons where we did stem cell injections in all the muscles that were involved. I had a patient with these were patients with very symmetrical spasticity, and so we did a trial where we injected stem cells into those muscles, and then we injected collagenase into the muscles on the other side, and the collagenase had better results when it came to spasticity reduction even than stem cells. Of course, those were more immediate assessments. Like, I don't know the long-term benefits of the stem cells. Maybe they may be a lot more persistent. But yeah, it's pretty profound. So, yeah. Yeah.
I was trying to Google where I could potentially get the treatment.
Oh yeah, yeah.
And one place that I found said that they won't administer to pediatric patients because FDA doesn't approve it for under 18. Is that
So I didn't really talk too much about insurance coverage, things like that. So it's going to be more of an out-of-pocket therapy typically. Although the good news with with Shockwave is often we can have the physical therapy visit billed through insurance per usual, and then the Shockwave will be offered as an extra add-on fee. So yeah.
Finds that Amazon offers it for $1,200. You can buy the machine.
I know. I've seen some patients get that. I can't say, I don't know for sure the utility of those devices. It's possible they could be helpful. I can't really attest to it. Yeah.
Is there a safety, which we watch for safety-wise?
I know it gets a little bit, with some of those untested devices. It's hard to say. I mean, I have had some patients get those, and they seem to like it. It's not quite as impactful as the device that we might have in a more medical setting, but I really can't say. Yeah.
So, what threshold did Botox have to hit that the laser has to hit in order to be FDA approved? Like Botox, which is seems more detrimental or
Right,
not
right.
as
Yeah.
effective, is approved. How come the laser, where the the shockwave therapy.
Yeah, right. Well, it's interesting with, when it comes to clinical research, there's not like a different threshold based on the safety of the treatment. So, it's based on a certain number of clinical trials being, largely driven by pharmaceutical research in most cases. So, with Botox being the best example. Yeah, we don't have like a really strong shockwave. Yeah.
Just get this trial going so that it can be used more widely, and then people can pay for it through insurance.
Right, absolutely. No, hopefully that's coming. I'm sure it will be. We have been getting more like add-ons to the list of indications that are approved with in recent years, and so unfortunately most of this research is not happening in the U.S. Almost all of it is in Europe or Asia, and so the U.S. is actually quite behind when it comes to this stuff. Yes, yeah.
So if I were to find a practitioner that's open to trialing this or
Yeah.
learning this skill,
Yeah.
is there any way that I can send them for more information? Or
Yeah.
do you guys offer classes for practitioners?
Actually, I was just talking to Darla about that. We do hope to eventually offer practitioner trainings, but we don't have like a time or date set for that, so it's a little bit indeterminate. I've personally counseled a lot of people. Usually with my patients, I'll either via phone or email, I'll connect with that local practitioner, send them what I've been doing that's been working, and it's thankfully a pretty safe device, and so I feel pretty comfortable just virtually training people too. Yeah.
So if I gave them like your email, would that be appropriate for them? Because I have a lot of practitioners like in my daughter's care that
Yeah.
are very open to
Yeah.
trialing things.
Yeah.
They just don't want to go to like Google.
Right. Absolutely. No, I always enjoy working with open-minded practitioners like that. So yeah, happy to connect.
Very abrasive, so. Probably want the guidance.
Yeah, absolutely. Yeah.
I'm from Mechanicsburg, Harrisburg, Pennsylvania.
Oh, sorry. That's okay.
Anyone has ever, if you've heard of any experimentation with coupling the other interventions using something like an oxygen concentrator, even chlorine dioxide solution, CDS, because there's even PubMed studies when it breaks down, it releases oxygen when it oxidizes another substance to kind of mimic a hyperbaric oxygen chamber effect.
I can't. I guess I can't speak too much directly to that, but I definitely have seen benefits in combination with hyperbaric oxygen. So we have that in our practice, and ideally, I love to throw a patient into the chamber after they've had their shockwave treatment. I think it really maximizes the results. Yeah.
If we can't afford it and it's not reimbursable, something
Right.
that isn't going to be quite as effective, but is so much more accessible.
Right.
Where you could, do something like an oxygen concentrator. You could do something like external, internal CDS, and then have this treatment because of the sound wave effect. It would kind of mimic the pressure of the hyperbaric chamber.
Yeah, I mean the shockwaves are pretty local, so whereas the oxygen treatments would be more global. But I mean, especially with a portable oxygen concentrator, that's pretty safe to try. I can't see the harm in it. I think typically it may be a slight extra benefit. It's hard to say for sure, though. Yeah, absolutely. Yeah.
Three thoughts.
Yeah.
One of them, there is one machine for the radial shockwave that they did with the Alzheimer's. In America, it's a study being done at Harvard right now.
Nice.
I
Yeah.
wanted to get some of the total wellness patients on board so that they could see the effects of that.
Nice.
in the Harvard study. So hopefully I'll be able to get that accomplished. We'll see.
Exciting. Yeah.
But to let everybody know that Dr. Lopez, Dr. Ryskowski, Amanda Ryskowski, and my husband will be in this little annex room over here if anybody has any questions. And then third, Amanda, I'm removed from the compilations that you put together for protocols and different tiers in the concierge service. Could you speak to that, how it includes already the
Yes, yeah.
radial shockwave as well as the HBOT as well as the stem cells as well as any medications or liposomes that you guys make for your patients? That's a really incredible all-in-one get your best bang for your buck when a patient or a family comes, that's something really, I think, important.
Thank you for mentioning that. Yeah, so at this time, I'm not charging extra for Shockwave with my stem cell patients. So I think all of us are doing that. So we generally just try to set our stem cell patients up for success as much as possible. And so usually extra things like Shockwave are just included. So as well as like supplements that are designed to optimize the intervention. So it comes with, our treatments are pretty comprehensive, including things to support patients in as many ways as possible. Yeah.
Do you work for Total Wellness?
She's Dr. Perfect's wife.
Oh, wonderful.
Dr. Ryskowski's here today from Total Wellness. Dr. Lopez, could you stand up so they can see you? So he's been working at the clinic for 15 years. How long have you been?
Since 2012.
And then Dr. Ryskowski, what she's done and the training that they've all had in the musculoskeletal ultrasound so that they can do the ultrasound guided injections, that nowhere else are the doctors having this much resources at the hands and in the hands of the doctors for one patient at one time. It's pretty incredible.
So when you sign up for the clinic, because you guys don't have a website, right? It's email. So
Yeah.
I
I know.
Have more freedom to help the families, because if you get advertised, then you get them coming down and shutting you down.
So you don't have to preach to them.
So I'd say reach out to Liz. She's our patient care coordinator if you're interested. I do eventually have a personal website coming, just a really simple one. I wanted more information to be available for my patients, but it'll probably be done next year sometime. Exactly. Yeah.
We see Dr. P and we
yeah.
had Shockwave just, when you guys got
Yeah, yeah.
but as somebody was asking about what you could have in home.
Oh, yeah.
I finally just got a vibration.
Yeah, yeah. Nice.
I haven't even pulled it out of the box yet.
Yeah.
Last week. But I know that it's totally different, but is it of the same? Yeah, that's a good question.
Right. You're not gonna get like, the kind of clinically validated results that we'd see with this, but it's still, it still is stimulating the muscles, helping to reduce atrophy and fibrosis. Absolutely. Yeah. Right. Yeah. Yeah. In a sense, all the physical therapies, all of these things work to combat fibrosis and atrophy together in the same way. It's, this just gives us an extra boost to really accelerate that process. Yeah.
Does the vibration plate affect as deep as this would?
Not like this. Yeah. But a lot of my patients really enjoy it. Yeah. I saw a question in the back.
So, as for vibration, the other one that I like to use, just to throw it out there, is the massage gun.
Yeah.
Very simple.
Right.
But it's got a closer effect to the Shockwave and that aspect of going into the muscle.
Right. Absolutely.
But Shockwave is definitely more intense.
Right. I think he just said a massage gun. Yeah, just as something to be used at home safely. Yeah. Yeah. Oh, nice. Okay. Nice. Yeah. Hi, sweetie. Oh my goodness, is that from Zay?
It's for somebody else.
Wow, good job. But yeah, thank you everyone, and we'll be in that room if anyone has extra questions. Yeah.